Hi, Savannah. How are
I'm
you?
doing great.
I'm Nicole Shen from Houston, Texas, and we have the lovely Savannah here again today. We're actually in the same time zone and in the same geographic area. Normally, Michelle's coming from Michigan. SDSF Live is brought to you from the Schwachman-Diamond Syndrome Foundation, providing support to families around the world. Welcome to SDSF Live. Let us know where you're logging on from. We are currently live from Facebook. We might be live from YouTube again today. We've been having issues with that. You can comment from both platforms and you'll see it on your feed. The show is public. We do ask you not to share any personal information that you're not comfortable sharing. Please don't ask very specific questions. These doctors are here to answer very general questions. These shows do serve as a library of topics on YouTube to families to access later, where it can be translated into many languages. Savannah, we're so excited to see you.
Thank you. I'm so excited to be back again. I'm excited to be with everyone this evening. Please let us know in the comments where you're logging in from tonight. And our guests this evening are with the SDS North American Registry. We are kicking off our camp series, walking our viewers through the basics of SDS. The first show will cover SDS 101. Akiko Shimamura MD PhD is the director of the Bone Marrow Failure and Myelodysplastic Syndrome program. She's also a professor of pediatrics with Harvard Medical School. Her focus has been aplastic anemia, bone marrow failure, cancer predisposition, and myelodysplastic syndromes, or MDS. Karyn Brundige is a clinical and research nurse practitioner in the bone marrow failure and hematology programs at Dana Farber, Boston Children's Cancer and Blood Disorders Center. She has presented multiple talks and posters at local national nursing conferences. Her passion is patient and family and nursing education. Please welcome Dr. S. and Karyn. How are you both this evening?
Hi.
Hello. Hi,
We
Savannah.
have a guest from Australia. So we were just telling Karen's a first time guest, and we're just letting her know that people log on from all over the world. So we have someone from Australia already. Welcome, all our viewers. So we're going to have you guys present first, and then we'll read the viewers' questions. Thank you.
Terrific.
We're going to turn the show over to you guys.
Terrific. Thanks so much. So wonderful to be here. It's always a pleasure. This is a wonderful, wonderful webinar series that you have put together. And it's always such a pleasure and an honor to be here to join you. I'm really delighted to introduce Karyn to you. She has been my partner for many, many years on the clinical side and now also on the research side. She's joined the SDS Registry team, and we look forward to having her work more closely with us on the research side as well. So I'm going to share my screen. Let me see. Let's see how I do this. Okay. So is that successful? Is that showing up okay? Yes? Okay, I see it now. Okay, so I'm going to just put it on my screen so that I can see it. Let me know if there's an issue with it, because otherwise I won't be able to read it. So I thought I'd do something a little bit different this time. You know, typically at camp, we have SDS 101. And I wanted to try to have something here for both people who are new to SDS, as well as people who are aficionados in SDS. They know all about SDS. They want to know what's new, what's exciting, what is cutting edge. And so I've included a little something, hopefully for everybody. And in putting this together, I queried our SDS registry team. You know many of them. And I asked them, what are the common questions that are coming in to the registry? And also Karyn and I, through our work in the clinic, have also identified sort of common questions that come up. So this is going to be an SDS FAQ. So let's start with some questions. So this is a basic one, right? So what are the medical complications of SDS? And the first thing to remember is that everybody is different. And to be honest, even physicians sometimes need to be reminded that the textbook description of SDS does not apply to everybody. Everybody's different. Some have very severe multiple complications, and some don't even know that they have SDS until they run into trouble later. So everybody is different. You can't extrapolate necessarily from one patient to another. However, there are common complications that can occur in SDS, and I've listed many of them here. And I'm not going to go into a lot of detail at this point, but what's important is you need to be aware as a parent or a person with SDS to be aware of these potential complications, both to keep an eye out for it, as well as to be proactive, right, to prevent complications or mitigate complications. So low blood counts, it's very important to be followed by a hematologist. If the blood counts are very low, bleeding or infection or anemia can be a problem. There's a lot of gastrointestinal complications that can occur with SDS, sometimes even without overt diarrhea. There can be nutritional deficiencies that patients benefit from supplements in such cases. So it's important to be evaluated by a gastroenterologist. Liver abnormalities are also common. Poor growth can be seen. Often people with SDS might be shorter than people without SDS, but the rate of growth should be normal, right? So if the rate of growth is not normal, there's something else going on and it needs to be attended to. Bone abnormalities can be mild or absent or clinically, I guess I should say clinically undetected, but there can be severe malformations, particularly of the chest, but there can be orthopedic issues with the hips, the legs, as well as low bone density, which is quite common, and we can talk about that. One of the things, some of these other things don't affect daily life sometimes so much, but often what we hear in the registry is one of the biggest impacts on daily life is neurodevelopmental sort of issues that need to be addressed and helped, learning disabilities that need to be evaluated and sort of strategies put in place to help people learn, ADHD, attention deficit hyperactivity disorders, or behavioral issues, anger management. These things, many people can benefit from help with SDS. We in the registry have identified multiple people with inflammatory complications, inflammation of the eyes called blepharitis, arthritis, multifocal osteomyelitis, etc. This is something that bears attention. Endocrine, meaning hormonal issues, immunologic abnormalities have been variably described. The most feared complication in SDS is leukemia, and there are multiple others, right? So what do you need to know about these complications? You need to know which complications to look for, but what's important is many of these complications are treated the same way in SDS patients, people with SDS, as they are for anybody else. Hypothyroidism is hypothyroidism, whether you have SDS or not. The evaluation for neurodevelopmental issues or learning disabilities, behavioral, the evaluation is exactly the same, whether or not you have SDS, and the treatment and interventions are exactly the same, whether or not you have SDS. So the important thing is to know that you have to look for them and that you or your child need to be evaluated for this at regular intervals, and we can talk about that at the end if people have questions. But you don't need a special SDS sort of expert for that. You need to go to an expert in this field, and it's treated and evaluated exactly the same way, right? And similarly for most of the other complications, except for the blood problems. The blood problems are evaluated and managed somewhat differently for SDS, and you have to be very careful about the management of the blood complications, and you need people with expertise, doctors with expertise in SDS, right? So that's very, very important. Oops, maybe that was the third point. Now, just because someone has SDS doesn't mean that you should just automatically ascribe every medical complication they have to SDS. They require, anybody with any symptom requires and deserves a full evaluation. So if you have anemia, we shouldn't just automatically assume it's from your SDS. There are many treatable causes of anemia that should be evaluated. So it's important that your doctors keep an open mind and not put on blinders and only look at one thing. I'll give you an example. I had a patient with SDS. He was little and he was not growing well. And he was developmentally delayed. He wasn't meeting his milestones, right, of talking when he should, walking when he should. And so we sent him for the same kinds of evaluations that we send any other child with these sorts of issues. Now, you can see poor growth and you can see developmental delays, delayed milestones with SDS, but it turns out it was good that we did this because he had hypothyroidism. His thyroid levels were low. And when we repleted that with medication, his growth caught up, his milestones caught up. He did ever so much better. So you don't want to deprive a child or an adult of appropriate treatment by inadvertently just blaming everything on SDS. You have to keep an open mind. Then the other issue that you have to be careful of is relying heavily on basically data that might be information that might be outdated or perhaps not relevant to you or your child. The internet often has very old information, or it may not be appropriate. It may not actually be appropriate, may not be relevant to your particular situation. Word of mouth is also, can be very helpful as a supportive thing, but can also be very dangerous. It's sometimes something that worked for one patient is totally inappropriate for someone else for different reasons. So I would encourage you to have an open discussion with your doctor to make sure that you understand what is appropriate for you or your child, and be frank. My patients, I encourage them to ask me questions of what they've seen on the internet or what they've heard through word of mouth so that we can discuss it, right? And sometimes it's something that is appropriate and we should absolutely, it's very relevant and we should pursue that. And other times it's not, and then I explain why not. So it's very important to have a transparent discussion with a physician you trust. Okay, next question. I do not live near a medical center experienced with SDS. How can I access expert care, right? Not everybody lives near a center with a lot of doctors who see lots of patients with SDS. That's okay. We need to figure out how to get you still great care. So there's a couple of strategies that you can take. So this is, again, something that I wanted to mention several times because it comes up a lot. Most medical complications of SDS, except for the blood issues, are evaluated and treated the same as for people who don't have SDS, right? So just because you don't live near an SDS center doesn't mean all is lost. You just need to know who to go to for your evaluations. You need to go to a bone doctor because we need to be careful about your bone health. You need to go to a gastroenterologist because we need to be careful about your liver and your vitamin issues and your pancreas. That should be appropriate no matter where you are. However, again, bone marrow failure or malignancy needs different kinds of approaches. You need to have expertise in SDS for that. That is very helpful. So what can we do if you don't have that? I'll get to that in a moment. If you don't have that available. For surgical procedures, so I've had patients going for surgical procedures, it is essential that a hematologist experienced with SDS or the issues relevant to SDS co-follow with the surgeon. There can be complications that develop. SDS patients are at higher risk for complications, and the management of that often does not fall within the expertise of the surgeon, and it's really good for them to have a partner, hematologist, local hematologist, with expertise in SDS. And if you don't have that, you might consider going for certain procedures to centers of excellence for SDS. Now, what do you do if you don't have ready access to that? We have set up something called the SDS board through the SDS Registry. If you log into the SDS website, there is a Contact Us button, which I'll show you in a moment. If you click on that, you can type in, oh, I have a question, I'd like to talk to somebody. And someone from our team, Karyn is highly experienced, Dr. Myers and I are highly experienced with SDS, and we're happy to try to set up a discussion with you or your doctor, depending on whether your doctor is reaching out to us or whether you're reaching out to us. But this is available for doctors as well as physicians, and it's something that we're trying to offer to everybody in an effort to share all that we've learned through the registry in partnership with everybody who's participated in the registry. So huge shout out to all of you with SDS who've shared your information and your samples. That is why we've learned so much about SDS, and we want to share that right back with the patient community and the physician community. So before I go to the next frequently asked question, let's do a little bit of background about SDS diagnosis, because this comes up a lot, and this field has moved forward a lot, and this is approached differently on the research side of genetics versus clinical care genetics. So I want to spend a little time on this. So in the old days, physicians and geneticists relied heavily on clinical features for diagnosis. And for SDS, the canonical symptoms were bone marrow failure, low blood counts, pancreas problems, and it's the exocrine pancreas, the digestive pancreas. So low blood counts, digestive pancreas problems, and sometimes skeletal problems. And that's how it used to be diagnosed. But through the work of Joanna Ramans, the first SDS gene was discovered, and I'll talk about that in a moment. Why are clinical features, why do you have to be careful about relying too much on clinical features? Well, number one, as I just told you, they may be absent, right? We have patients with SDS with normal blood counts, right? And unfortunately, some of our patients, the first time they actually realize that they have SDS is after they've developed severe complications, such as leukemia. We just had several SDS patients join the registry because they presented with leukemia or MDS, and then their doctor sent off SDS testing. So you may not have any of these other findings, and you're actually not required to have any of these for the diagnosis of SDS. So if you don't need these clinical findings, how do we make the diagnosis? We rely on genetics. Now, you should not rely just on genetics. You need to go to a clinician, a physician who's comfortable with SDS, who understands SDS, has knowledge about SDS. And we do a very careful clinical evaluation and genetic evaluation. And I'll tell you why in a moment. Genetics are not perfect. You have to do both. But if you find what we call pathogenic mutations in the SDS, SPDS gene, and they're biallelic, meaning both copies of the gene, we all have 2 copies of most genes. If both copies are mutated, then you can make the diagnosis of SDS, even if you have none of the other symptoms of SDS. There are additional genes that have been described, and we've described some of them, that can share clinical features of SDS. They can overlap with SDS. Whether or not these should be called SDS, we don't have enough clear data yet. And the reason I make that distinction is once somebody is labeled with a diagnosis of SDS, it implies certain management, certain treatments, certain approaches. And we have to be careful for these patients with EFL1 mutations, DNAJC21 mutations, SRP54 mutations. We need to keep a more open mind and do a lot more research to understand how best to tailor therapy for these conditions. And I'm happy to answer questions about that at the end, okay? So we're calling these SDS-like conditions, meaning they share clinical features of SDS, but instead you have an EFL1 type of SDS-like condition or a DNAJC20. So we incorporate the gene into the diagnosis. Now we have a large subset of patients, both in my clinical practice as well as in the registry, who have clinical features of SDS, but all genetic testing, SPDS, DNAJC21, EFL1, SRP54, all of that is negative. What does that mean? What now? Well, there might be several possibilities that might cause this. So let's explore some of them. So one possibility, which we've seen, is the mutation is missed. So you have to consult with an expert in SDS genetics. And I have to share with you a story. Karyn Brundige, my partner, was seeing a patient over on our bone marrow, not our bone marrow failure clinic, which is where I see patients, but in our general hematology clinic. And she had been referred because her platelet count was a little bit low and she was supposed to go to surgery. Karyn saw her and she's like, oh, this patient needs to be evaluated for SDS. But the patient had been seen previously in GI clinic and the testing had been sent and it was negative. She didn't have any of the mutations. So Karyn contacted me. And we did a really deep dive into this, and we found that the mutations had been missed. She had 2 mutations in SPDS, but the gene is very tricky to sequence, and it's very easy to miss the mutation. So you have to really dig then. So we dug, we found the mutations, and she is now getting appropriate treatment. So If you're not sure, we are a resource for you. In particular, people who have only one mutation and they can't find the second one, we can be very helpful there as well in trying to determine whether there might be a missed second mutation. We have other modalities on the research side that can help us figure that out. Another possibility is that you or your child actually have a completely different diagnosis, right? We've also found that. So we've managed to find diagnoses for some of these patients who have clinical features of SDS, and the diagnosis actually has nothing to do with SDS. We had one family who had an inflammatory disorder. It's a gene that causes an inflammation, which can affect the bone marrow. It can affect the GI tract. It can affect neurocognitive. It can affect the bones. It can affect a lot of things because inflammation affects a lot of organs, right? So we found that gene. We had another patient with a completely different gene that caused pancreas problems, and they didn't know that it could cause it, but we learned that it can cause neutropenia and skin findings. They thought it was eczema, but it actually wasn't. We found another gene that was a mutation in a gene that we're still figuring out what it does, but it seems to affect transcription, et cetera, et cetera. So we're finding a lot of new genes. We found another gene that affects, it's called a ciliopathy. It affects the cilia, and it caused a lot of symptoms similar to SDS. So it really helps to have a deep dive broadly, and we're finding answers. Now, as I said, we're finding diagnoses that we know about and they were just missed. Or sometimes you or your child might be teaching us something completely new. Some of these genes that I just described to you are completely new genes. I just presented at the European Hematology Association. They wanted to hear about a new gene that we had worked out with another group that can present sort of like SDS. So, we can learn a lot from studying and working and partnering with people who have genetically undefined SDS-like disorders. Another possibility is it's not a simple Mendelian genetic condition. So, so far, all the conditions I described to you are one gene causing a condition. But there are other things that can happen that can also cause conditions. And there's lots of possibilities here, and I'm not going to go into the details. It's a very science-rich thing. We can talk about it some other time. One thing that I wanted to make people aware of is that participants on the SDS registry have at their disposal these new genomic analyses. What I just described to you is a lot of work that we've been doing in the SDS registry, finding new genes. And the technologies are advancing very rapidly. I give Dr. Rahman's huge shout out. She discovered the SPDS gene back when we didn't have any of these tools that we currently have. But now we have very powerful and ever advancing tools to discover new genetic conditions. So I want to give a shout out to the team. I've assembled a team that I lead together with Dr. Mark Fleming, Dr. Ann O'Donnell, and Dr. Stephanie DeTroya. We all bring different areas of expertise to this. And we all work at either Boston Children's Hospital or at the Broad Institute of MIT and Harvard. As you all know, the Broad is world famous for their cutting edge technologies, as well as their advanced analytic pipelines. So we have access, we can give you access to all kinds of very powerful new tools to try to help us find your gene if you participate in the registry. So it's a service that we offer through the registry. I just also wanted to say that in addition to the registry, some people have opted to go to a center with expertise in what to do about genetically undefined conditions. So we are one site. There are many others around the country, but just in case people are interested, I just put up here our bone marrow failure and MDS program, and Karyn works with us here. And the reason that I wanted to mention this is we partner with the adult bone marrow failure program. I actually helped partner with them to set that up, and working very closely with Chris Riley here on the right, as well as Richard Stone there on the left, and Lachelle Weeks in the middle. Dr. Stone is a world-famous expert in bone marrow failure and leukemia on the adult side. And Chris Riley is just a terrific hematologist, oncologist, and researcher, working with Dr. Stone and Dr. D'Angelo on the clinical side, with me and Dr. Coleman Lindsley. He's in Dr. Lindsley's lab on the research side. And so I just wanted to let adults know that this is a resource available to you. We've actually taken care of families. Sometimes the kids come see me and then their affected parents go to see Chris. So it's really been, and it's also, I think, nice to know for the children that as they grow into adulthood, that we can provide continuity of care. And we hold a weekly research conference where we present patients to each other and we maintain a very close dialogue. So that's very helpful. So, another frequently asked question. I feel fine. Why should I bother with bone marrow surveillance, right? This is an excellent question. It ain't broke, why fix it, right? That's basically what people are asking, and it's a very reasonable question. But there's some things that some facts that you should know in order to inform your decision about whether or not bone marrow surveillance is right for you or your child. Number one, once leukemia develops, we do not have great treatments. It's very, very hard to cure. It's not incurable. We can cure leukemia. We've done it. We have a wonderful little boy who came to us with leukemia. His doctor was wonderful and contacted us right away so that we were the first to treat them. They didn't lose a lot of time with local therapy. They came right to us. We got the treatments going right away. He's a long-term survivor, knock on wood, still in remission, many years out, excellent quality of life, no graft versus host disease. And he had an unrelated donor transplant. But for most patients, it's very, very hard to treat. So I'm giving you examples of hope, but for the most part, it's really tough. And so you don't want to be faced with that. You want to intervene before the leukemia happens. And that's because survival is excellent. As a matter of fact, so far, everybody who we've transplanted prior to leukemia has done well. They have not had severe graft versus host disease. They have not had problems with survival. They've all survived. They've got great quality of life. Now, this is in recent transplants. If you look in the old days, and this is where a lot of people are quoting data, the old days, our transplant were not so good, right? We were not good at unrelated donor transplants. We were not good at mismatch transplants. We could not do what we call haplotransplants with a parent as a donor. But the field has advanced. Do not allow old, outdated data to color your thinking. You need to base your medical decisions on current data, right? So contact your doctor, contact us, learn what's recent so you can make the right decision for you. Now, the other thing is, it ain't broke, don't fix it, is the problem is by the time it's broke, it's often broke because the leukemia has developed, right? So it feels really weird and it feels like a disconnect to go to transplant when you or your child feel great, right? But if you wait till you feel sick, it might be too late. You might be feeling sick because of the leukemia. And we've had case after case where that's been the issue. Now, that's a problem with physicians as well. We're trying to teach physicians, you need to be vigilant and intervene before the leukemia. So keep a close eye out for signs that the leukemia might be lurking around the corner. Don't just sit back and feel good because everything is looking good, right? The other issue is I hear people say, I thought I had mild disease. The doctor says, I thought they had mild disease because their blood counts weren't a problem. They were only mildly low or they had normal blood counts. And so therefore we thought there was a low risk of leukemia. But this is not the case. Oops, this is not the case. That didn't work out, sorry. This is not true. And we've seen time after time, people thought they didn't need to worry about surveillance. They didn't need to worry about leukemia because their blood counts were fine and they felt well. So I just wanted to put it out there just so that you're aware that just because you feel well doesn't mean you're not at risk for leukemia if you have SDS. Another frequently asked question, I know people who have had surveillance, but they still developed leukemia. So why should I bother with bone marrow exams? It's painful, it's inconvenient. What's the point, right? Now I'm going to say nothing is perfect, right? There's no perfect test, but don't base your decisions on outdated data. So in the old days, this is what we had. And by old days, I mean a couple of years ago, right? This is how we were doing surveillance. So this is a patient who is having, so each one of these marks is a year. And that's the year that this child was having bone marrow surveillance. And the blood counts in the bone marrow looked fine during all these years, right? And during this year, there was a little tiny isochromosome 7q clone. This is a cytogenetic abnormality that is very common in SDS, and it was growing and growing and growing. It originated from, these are bone marrow cells, it originated from a single cell, and that cell proliferated and gave rise to lots of cells in the bone marrow, right? But interestingly, over time, it disappeared and became undetectable, right? And sometimes that happens. And so everybody was breathing a sigh of relief, blood counts were fine, until lo and behold, she had this marrow. And this marrow, the bone marrow started to look weird. The bone marrow cells started to look abnormal. But everything else looked fine, right? So the transplanters were appropriately taking time to try to find the best donor who was as matched as possible, because it was hard to find a fully matched donor. And during that time, because there was a huge delay. Now, we had some donors we could have used, but they opted to delay to get the best donor. And during that time, she developed MDS, right? So she developed a malignancy. So this happened with the standard, let's look what the bone marrow looks like, let's do cytogenetics, let's do FISH, right? What we didn't have is what we have now, which is molecular analysis, doing somatic mutations. And so in retrospect, because she was on the registry, we were in retrospect, once this technology became available, we worked with Coleman Lindsley, who is an expert in this kind of analysis, and found that many years before she developed her malignancy, there was, by somatic mutation analysis, you couldn't see it by regular bone marrow surveillance that everybody was doing at the time, and frankly, most of them are still just doing that. By somatic mutation analysis, we could see this clone arising from a cell starting to grow with this ominous mutation that then developed it picked up a second mutation. And then at the time that it developed into malignancy, it had picked up a very characteristic mutation that's common in pediatric malignancies, right? So now that we can add somatic mutation analysis, you can start to capture things that previously we couldn't, right? So far in the registry, we don't have anybody who has developed malignancy when getting this kind of analysis, but it's still early days yet. It's only within the last couple of years that this additional analysis has been added to the bone marrow evaluations, right? So we have to see how effective it is, but we've already caught many patients where we're seeing ominous things happening, and we're able to share with them that they have an option at that point of discussing whether they want to go to transplant at that point. So it gives you options, right? Now, one of the things that happens is, doctors we've done a lot of work, we've published this work, we've talked about this work. So doctors are starting to send this analysis, but they don't know what to do with it. So again, doctors can contact this SDS board that we formed with Dr. Lindsley, Dr. Riley, Dr. Myers, etc. And you can call and ask us. And we've had fielded calls from all over the world. We just got off a call with Denmark. There was doctors in Denmark who said, we see these mutations, what do they mean? And we can share with them what we've learned through the registry, right? We don't tell doctors how to treat their patient. They're the doctor. They have to come to see us for us to make a decision about treatment, but we can share with them information that the registry has learned, and they can then use that to guide and inform their treatment of their patient, right? Frequently asked question, can surveillance be done on a blood sample, right? It's a great question. You can do somatic mutation analysis in the marrow. Can't we just do it on the blood and just not bother with all this painful, inconvenient, horrible bone marrow exams? And I wish I could say yes, but the short answer is actually we don't know yet. I don't know whether that will be sufficient. So I know there's a lot of doctors that are running around saying this is adequate. I would say we don't have the data for that. And the reason is we cannot assess for the abnormal appearance of the bone marrow. We've had a lot of patients whose marrows have started to look abnormal, even without ominous changes in the mutations. And I just heard about a case from actually an experienced SDS doctor who told me the marrow started to look funny even though the mutations looked stable, right? So you need to kind of look at how the marrow is looking, because that can give you additional clues. It's not just the mutations. You have to look at everything. It also, if you look in the blood and do mutation analysis, you cannot assess for chromosomal abnormalities, which you can assess in the bone marrow, right? And sometimes the chromosomes can give you clues that something's going off. The other issue is, and this has been shown not in SDS, but in other situations, the blood is not as sensitive as the bone marrow in trying to assess for early signs of a problem, right? It's been shown clearly that once someone has a malignancy, MDS or leukemia, the blood is just as good as the marrow. And I think it's because those malignant cells are circulating in the blood, so you can catch everything in the blood just as easy as you can in the marrow. But for people who don't have a malignancy, but they're starting to bruise something in the marrow, there are data showing that the marrow is not as sensitive as the blood. Whether that's true for SDS, we still need to check, but that gave me pause, and I'm not comfortable recommending just blood without a marrow if people really want to have, full court press surveillance. Some people don't want that, and that's okay, but I think that we just need to give everybody, parents and adults, the information they need to come up with the right decision for them. Does the SDS Registry actually do research? Now, I have to say, I sorely regret having labeled our effort an SDS Registry, because it sounds like we just register people, like we sign you up and we make a little list of you and that's it, and we're done. That is far from the truth. What I should have called this is an SDS consortium. This is a research consortium to advance the cause of SDS, people with SDS, to improve your health. And this is a partnership with the patients, you, and it's a partnership actually with a whole team of investigators we've assembled through the registry that I'll tell you about in a moment, right? So I should have called it something like an SDS collaborative or something like that, because we are so busy doing research. Now, I'll tell you that we've used our expertise, Dr. Myers and I have utilized our expertise scientifically and clinically to assemble a team of world experts in the clinical side and on the research side. And we're partnering carefully with them. They're often physicians and researchers. Some of them have never worked on SDS before. And so we provide expertise in SDS and help fashion the questions, but they contribute world-class expertise. So let me share some of this with you. So this is the clinical expertise that we need to care for patients with SDS, right? And we've recruited experts in many of these areas to both in the clinical care of patients and also in some cases in the SDS registry. Some of you have met Dr. Grover, who's an amazing GI doctor. We have transplanters, oncologists. I have an endocrinologist I work with, and you just heard from some of our neurodevelopmentalists. I just told you about some of the geneticists. So these are vetted, productive people, researchers who work well as a team, right? So you have to meet all those check bars. You have to be a world expert, you have to work well in a team, and you have to be committed to SDS and working on SDS. So some of the things that we're doing are developing novel therapies to prevent bone marrow failure and to prevent leukemia, right? Now, we want to also treat bone marrow failure in leukemia. So we're doing two things. We're going to do prevention. We want to also treat it once it starts. And we've assembled a whole team of people. We are working on gene therapy for SDS with Dan Bauer, who did the sickle cell anemia trial here, and his work has been written up in the New York Times and the New England Journal, and he's been very, very productive. He's terrific. And what's great about Dr. Bauer is he partners with the FDA. He just met with the FDA and with pharma to move things into clinical trial. I'm working with a world expert in mouse modeling, Dr. Orkin has he has accolades from pretty much every scientific society. He's amazing. And our mouse models are really looking really terrific. We just submitted an abstract to ASH on that. And Dr. Bauer is leading that with Dr. Orkin and Christian Brendel. We also are looking on therapeutics, other therapeutics, bioengineering, et cetera, and I'll give you a list in a moment. And these have all been either published or submitted for abstracts at the upcoming ASH meeting. gene therapy I just talked about, precision medicine. Can we predict, right, who is about to develop leukemia so we can intervene, right? That's precision medicine. And we're working very hard with Coleman Lindsley, and now I've recruited other people to take complementary approaches to try for precision medicine to improve our sensitivity and hopefully eventually come up with non-marrow-based blood tests to do this, but that we're not there yet. We're also trying to develop better diagnostics, right? I told you we're diagnosing a lot of people with SDS-like conditions, some of whom have an SDS-related disorder, some of whom have completely different disorders, and we're still working hard on that. We're also looking at disease biology. We're also developing clinical trials to improve treatment. So Jess Pollard, who is an oncology expert, is partnering with pharma and with the Children's Oncology Group to include Shwachman-Diamond syndrome in these trials. We're partnering with pharma. We're partnering actually with our adult colleagues to do this, to make sure that these trials are available to SDS patients. Because the current treatments don't work. So we really want to get patients new therapies to see if they might work better. We formed, Dr. Williams, who is my division chief, and I have sort of seeded a national consortium of over 50 centers now across the country that forms a clinical trial network. And I head up the coordinating center to allow us to get clinical trials going, hopefully for SDS. So once we develop our therapeutics for prevention of bone marrow failure and leukemia, or other things, we can push that into this consortium and get the trials going across multiple centers. It's a rare disease. You got to have a clinical trial network to do this. This has attracted, I'll tell you, this has attracted the attention of pharma. So pharma has funded, Novartis has funded one of our trials. It's not a SDS trial, but we've completed that, and we submitted it to the American Society of Hematology for presentation. We have an NIH-funded trial that we've published, and we just got a second grant from the NIH to expand that trial. We've been very successful. We've also, through the SDS Registry, partnered with other international registries. So I just gave a talk for the French Neutropenia Registry. I was really excited to partner with them in this talk. We partner with our colleagues in Europe, in Israel, and I've talked to the group in the UK, and we're really fostering sort of dialogue, and hopefully we'll get funding. We got a great score on our NIH grant, but we're still seeing whether we're going to get the funding to do sort of international consortia studies on these conditions. So we're very, very excited about our international collaborations that we've set up. And then we're very, very committed through the registry to education. So that's partly why I do these webinars. We need to provide education, give back to you, the patients and the families. And we've now instituted, as I said, this SDS board. And I promise I'll give you more details in just a minute. What can I do to help the SDS registry improve the health of people with SDS? And the reason I'm putting this up is I get this question all the time when patients come to see me or they call me about the registry. So I would say there's two things you can do. Number one, get the word out about the SDS registry. Explain this is not just a registry where we register people. This is where we are actively working in partnership with you to try to figure out better treatments, better diagnostics, and prevention to improve your health. And it's not just about the blood. We are trying to work on all aspects of SDS, the GI tract, neurodevelopment, et cetera, et cetera. So the more people who participate and share their information, their medical records with us and provide samples, the faster this work will go, right? So a huge word of thanks. Everything we've learned through the registry has been thanks to all of the participants, many of whom are on this call. I'm seeing your names, and have tirelessly given your samples and your records year after year. For some of you, over 20 years you've been doing this. So, and that's why we are where we are at today. And people have been, this has caught the attention of other rare diseases. And I've been asked to help and provide sort of share my experiences and provide input for other rare disease groups. And actually just recently, the NIH asked me to participate in a thought group about how to make this work for diseases more broadly. So the SDS Registry, thanks to you, has been very successful and has garnered the attention of many other groups. So that's been, I think you're helping not only SDS, but I think people with rare diseases more generally. And that helps SDS again, because the more attention we get, the more, I think, resources we can get for SDS. Now, the other thing that people ask is, how can I support research with donations? And, there's lots of SDS groups getting donations for the research that they're doing. And I think that's great. There's lots of different groups trying to see different types of research efforts. But if you want to donate to the efforts that I just described to you, that the SDS Registry has worked so hard to develop with these collaborations across science, then this is the only way the money comes to us. If you donate anywhere else, that doesn't come to us. That's fine. If it's just that if you want funds to support the efforts that I just described, this is the only way to do it. You have to go to the SDS Registry website. This is the URL, and you click on this little donate button, and it brings you to this Boston Hill Children's Hospital Trust, which we just put it through Boston Children's, even though we partner with Cincinnati, but I work together with Cincinnati to allocate the funding appropriately. And so thanks to all of you. There have been so many of you who have so generously donated, but just putting out there, that's the only way actually that the money comes to the registry. Does the SDS, or for people who are fundraising, so we've had some individuals fundraising specifically for the registry, and they've worked with us, but there are certainly other groups doing their own research, and that's great as well. Does the SDS Registry provide resources for education and clinical care? So I hope that I've made the case to you that we do, but a little more detail here. We have an SDS Medical and Scientific Advisory Board where we've recruited leaders across different fields. We have the SDS Registry Board. So this is the input, and I thought I had this is it. If you want to contact us, either as a patient or your physician wants to, you go to sdsregistry.org, and on the opening page, there's this questions box, and you just click Contact Us, and it takes you to a link where you can contact us. And we will reach out to you then and try to find a time to talk to you. So I just want to leave a few minutes for questions. So thank you so much for your attention, and I look forward to taking questions.
Hi, that was awesome. I'm always so proud of y'all. That was fantastic. Michelle, I think, is coming in. She's here. I need to ask you both, do you guys have a hard stop at 7:30, or can we go slightly over? Because we have about at least 5 questions that came in.
Okay, let's see if we can get through 5 questions. We'll try.
Okay, ready? Lightning round. Okay. First question. My daughter has a copy of the DNAJC21 gene. Does she have to have 2 to be officially diagnosed?
Yes, so DNAJC21 is an autosomal recessive condition, so you do need to have 2 mutations to have the disease. If you only have 1, it's possible that they missed the other one, so you need to do a deep dive. Do work with someone who can do a deep dive. We're happy to work with you through the registry if you are a registry participant. And there will be, I forgot to mention, that we are hosting an SDS Registry Family Day. We will have our genetic counselors give a talk on the genetics because they are trained to explain this to patients and families. They do a much better job than I do. So I encourage you to join that. That will be on September 17th. And everybody who's on the registry will get, hopefully received, a notice about it. But everybody's welcome to join. Anybody, you don't have to be on the registry to join, but you do have to register to participate, like register for the conference. You don't have to register on the registry.
Right.
And the next question, are these genetic services something we will need to request when sending our kits in, or will these tests happen automatically?
That's so I'm not sure I'm following the question. If you're a member of the SDS registry and you don't have a mutation, then you are getting queued into our genomics pipeline. As long as you've agreed to, you have to consent. Everybody can get genetic testing of individual genes, but we have a very powerful technology where rather than looking gene by gene individually, which is very cumbersome and you miss stuff, we can look at all the genes simultaneously. And there are even more powerful techniques to look at the genome. So if you have to agree specifically, that's called whole exome, whole genome sequencing. And again, our genetic counselors will talk about this, but everybody will get queued into that. It does take time. And as some of you know on this call, you've been very patient with us. We're still trying to work through this. We're not the only ones. I just went to a discussion at the Broad Institute, and everybody, we have people working on kidney disease and hearing problems. We all have a whole cadre of patients where we're sure that there may be a gene there, but we can't find it. And so we're figuring out better technologies, and there's new technologies coming out all the time. So we don't give up. So that's that. Clinically, if you want genetics, then you should talk to your doctor, and you can request. And now, if you go to a geneticist, that may or may not be the right thing to do. I actually don't send my patients to genetics. Because you need a geneticist who knows these conditions. So if you can find a geneticist who knows the conditions, that's great. What we do is we know the conditions and we partner with our genetics experts and work together.
Okay. Are these somatic mutation analysis available at centers other than Cincinnati and Boston? If so, what should we ask our hematologists to order?
Right. So this was a somatic mutation. The panel that you're talking about was developed in Boston, and it's not available to outside centers. And I pulled a ton of strings to get it available at Cincinnati, because I know a lot of you go to Cincinnati, and Dr. Myers is a partner, and we managed to make that happen. So all of the samples are coming to Boston for the testing. This does not mean that Boston is the only center that knows how to do it. There are commercial platforms that do this. Boston does a very sensitive analysis. I don't know the commercial labs, and I don't know how sensitive they are. And I don't know how they do their analysis. Whereas I know that the Boston sensitivity and analysis has been set up with Shwachman-Diamond syndrome in mind, in addition to particular other conditions. So if you're not cared for at Boston or Cincinnati, I think your doctor can send to any of the commercially available centers, platforms, and that I think is fine. I just can't speak to it because I don't use them.
Could the local center also set up similar to how you guys are set up? Because it's like right at the threshold.
Yeah, it's an internal test, and they're not. There's reason. It's not that they're trying to be mean, but it's not set up to be a national test.
Yeah.
And I had to pull. If I start telling them you're about to get stuff from all over the country, they're going to kill me, because I wasn't even supposed to have Cincy sending it. Right. So I pretty much, I had to beg.
Okay.
Next, we have my daughter's neutropenia genetic panel included the genes known to be involved with SDS. No mutations were found. Should we be pushing for genome sequencing? We have already done whole exome sequencing.
So whole genome sequencing is certainly an avenue that you could pursue. And we just had a patient who was missed by targeted sequencing, missed by whole exome sequencing, and then came to see us. We did whole genomes and we caught it, right? So it can be done, but usually you catch an extra 5% of cases by whole genome sequencing. So I think that that's a very reasonable thing. You just have to have a center that knows how to do the analysis.
Okay, the next question is a specific question for a very specific patient. So we're going to message you privately and see if we could get the viewer's information. It's, I believe, someone that you were talking to on the phone. So it's not a general question. Okay. Oh, we did it. Did we get 4 questions in? Okay. Thank you.
I wanted to raise one other, because we still have a little bit of time, because we have Karyn on the line. There were some other questions that come to Karyn a lot. And I thought I'd raise them in case people in the audience were interested. So one question that comes up a lot is, my child has SDS. Is it safe to say, and they're neutropenic, is it safe to send them to school? What kind of precautions should we take? And there's some institutional variation here, but perhaps Karyn could talk sort of generally about an approach to that.
Yeah, thanks, Dr. Shimamura. So I think sending kids to school is something that is really important. I think a lot of us agree with that children really need socialization, and it's not just the schooling. I think we all learned that during COVID, right? That having our kids at home and on Zoom wasn't the same experience as having them in the classroom if we can do it safely. And so I do encourage you to partner with your local team as far as getting kids in the school. I think some of the things I think about are what the kids' blood counts are, what your child's blood counts are. So if your child is neutropenic, that's different than a child who's not neutropenic. And if your child is neutropenic, if their ANC is less than 500, then I think there's a few things that need to really be in place to have your child safely at school. And so I really encourage families to know what type of healthcare is at the school. Is there a nurse that's there every day? A lot of schools are sharing nurses, so the nurse isn't maybe on site, but is available. Is there someone on site who knows how to use a thermometer accurately and can check your child's temperature and will get in touch with you right away? The teacher, I think, needs to really be aware of your child's condition so that she can be on the lookout. Some kids might not, say, oh, I think I have a fever, right? But they might start acting differently. And so if a teacher has a higher suspicion or knowledge that a child with a fever, is more at high risk in the classroom, then they can be helping to keep an eye out for a child. And sometimes those are the people I partner with as far as making sure that a temperature can be checked to make sure a child doesn't have a fever. Even if your child doesn't have a fever, that doesn't mean that they're not sick. And so some children who are neutropenic don't get a fever. And so if they are sick and not feeling well, it's important that someone's going to be able to contact a parent, that parents have transportation, that they can get to the school or someone else can get to the school to pick the child up, and that you have a method of bringing the child to a medical care, whether it's to your clinic or to the ER, depending on what you do with your home situation, so your child can be evaluated quickly. But we have many children who are neutropenic who are safely in school because they are able to have someone who's able to look out for them, who's able to check a temperature. They have a parent who's able to leave work or home and get them and bring them in for evaluation if it's needed. So I think a lot of things to think about nowadays are, what's going on with COVID, are children being immunized, or is there a setup in your school so that you'll be notified if there's a lot of infection going around the school, whether it's flu or COVID or strep or mono. It's just helpful to know what's going on in your child's classroom so that you can make informed decisions about whether or not they should be in class that week or not.
And then the other question that comes up a lot is, my child's neutropenic. We want to take a family vacation. How can we travel?
Mm-hmm. It's so hard.
It's so hard, right? Yeah, it is really hard. So several things I think about for travel if your child is neutropenic. So if they are on GCSF, you want to make sure that you have a good supply of your GCSF. You want to make sure you have a way to keep it cold. So cold packs and all of your needles and syringes, and you want to make sure you keep that with you on the plane. You definitely don't want to put that in your checked luggage. I know there's been a lot of issues recently with flights and delays and baggage, so you want to make sure everything stays with you. I encourage families to really think about what their insurance coverage is. Some people are covered by state insurance that does not cover them when they go outside of the country, and other people have coverage that maybe also doesn't extend outside of the country. So especially if you're going to be traveling outside of the country, that's a time to really think about potentially purchasing really good medical coverage, insurance coverage for when you're going to be away. Even if you're traveling in the country, I tell parents it's really helpful to know where you're going to go and where the closest children's hospitals are to you. Frequently, your nurse or social worker can help you figure that out as well. It's really just nice to also go with a letter from your primary hematologist about who you are and why it's important that you get evaluated right away, and what type of tests they should do, and who they should contact with information, so that if you end up, if you're in New York and you go down to Disney World or something for a vacation, that you know where the nearest children's hospital is, and that your primary team is going to get contacted when you show up, if you do have to show up there with a fever. And I think also just being prepared, if your child did have to get hospitalized for a couple of days for an admission because you had a fever, are you prepared to figure out how to do that with yourself, your other children, the other people that you're traveling with? So I just had a family who's had to travel to the Galapagos because their daughter got COVID when she was in the Galapagos. Not an SDS patient, but a different family.
Oh, no.
So that can be very challenging. So.
Yeah, that was good information. Thank you. Okay, we're done with the questions. Anything else from y'all before we close out the show?
Thank you so much for doing it.
Thank you so much.
Yeah.
We ended at 7:30. I'm so excited about the timing. We did great. This was awesome. This is definitely going to be a show that we recommend over and over and over for especially new families, because it's just the information is so overwhelming when they first get diagnosed. We want to thank our special guests tonight. If you have more questions, please send them to Michelle or I or Savannah, and we'll get them answered for you. We want to remind everyone this work is not possible without the participation of the patients. Please join the SDS Registry. If this wasn't a good advertisement for the registry, I don't know what is. We are stronger together, y'all. And special thanks to Greg for running the behind the scenes tech to ensure this show runs smoothly.
Thanks, Greg.
And there's I was just going to put out the reminder, the SDS IEP toolkit to help keep kids safe with precautions and preventative measures on the last show that came up. And be sure to check out the upcoming shows in our camp series, including Hematology 101 and GI issues that are coming up.
Thank you so much. Thank you all. Thank you for coming. Have a great night.
Bye, everyone.